So, the main etiological factor and in a nutshell, we will see what happens in each of the COPD diseases. In chronic bronchitis, the main site of the lesion is in the bronchus, where there is mucus gland hyperplasia with hypersecretion from the glands. Smoking and environmental pollution are the main etiological factors, and the signs and symptoms include cough with copious sputum production. In bronchiectasis, so ectasia is dilatation of the bronchi. Here again the lesion is occurring in the bronchus. Here, as it is self-explanatory, there is dilatation of the airways with later scarring and fibrosis. The cause, it is persistent or severe infection which triggers an episode of bronchiectasis. Presents with cough with expectoration and intermittent fever. In bronchial asthma, again the lesion is in the bronchus. It undergoes smooth muscle hyperplasia with excess mucus production and inflammation. And the common cause is atopy or immunological, and in other non-atopic causes is also there for bronchial asthma. Mainly it produces as wheezing, also with cough and breathlessness. Emphysema is one disease where the lesion is not in the bronchus as in the previous three diseases, whereas it is in the acini, which is the functional unit of the lung. Here the air space undergoes enlargement with wall destruction. The triggering factor, as in any other COPD, is tobacco smoke. It presents with breathlessness or dyspnea. The lesser common small airway disease and bronchiolitis, the lesion occurs in the bronchioles. And pathological changes, there is inflammatory scarring or obliteration. Smoking and pollution, as in other cases, is the etiological factor with cough and dyspnea. We have to understand that there is an overlap between these various obstructive lung diseases. For example, chronic bronchitis and emphysema, there may be an overlap. If there is secondary inflammation, there is more predominant bronchitis. If there is destruction in later on stages, there is emphysema. Asthma, there is reversible obstruction due to bronchial hyperresponsiveness triggered by any pollen or allergens or infection. So, chronic bronchitis and emphysema, especially among the various COPD, have overlapping features of both, and smoking is the common triggering factor which leads on to these diseases, and small airway disease leads on to chronic bronchiolitis. We will take up one case history. 52 years old male with complaints of cough with expectoration, breathlessness and chest pain. He gives history of similar episodes every 3 to 4 months for the past 2 years. This is very important history, and this you should know that as we see any patient, history taking is very important to arrive at a diagnosis. So, he gives a history of similar episodes every 3 to 4 months for the past 2 years. And personal history, he is a chronic smoker and he smokes 1 to 2 packs of cigarettes per day for the past 5 or 6 years. And on examination, the patient is tachypneic with the fast respiratory rate of 32 per minute and mild bluish discoloration of the mucosa is there, which is cyanosis. Respiratory system examination shows an end inspiratory crackle. So, the diagnosis is chronic bronchitis. The definition of chronic bronchitis is very classical as in our case. Persistent cough with sputum production at least 3 months of the year for 2 consecutive years. That goes the definition of chronic bronchitis. Persistent cough with expectoration for at least 3 months of the year for 2 consecutive years in the absence of other specific underlying pulmonary diseases. So, this is the normal trachea and the bronchi, and here these are the alveolar air spaces. In chronic bronchitis, there is inflammation of the bronchi that leads on to mucosal hypersecretion. That is the pathogenesis of chronic bronchitis. It occurs in middle-aged men who are chronic smokers, and classically it goes by the description blue bloaters. So, because in later cases, later stages, it produces cyanosis. So, they are described as blue bloaters. There are various types depending on the obstruction that ensues following an episode of chronic bronchitis. It can be simple chronic bronchitis, chronic asthmatic bronchitis, or obstructive chronic bronchitis. So, it depends on the severity of the asthmatic component that occurs in chronic bronchitis. So, it can be in simple chronic bronchitis, there is productive cough but no airway obstruction. In chronic asthmatic bronchitis, the hyperreactive airways are there. So, it produces intermittent bronchospasm and wheezing. So, there is an asthmatic component is there. In obstructive chronic bronchitis, there is severe airflow obstruction. So, it is obstructive chronic bronchitis. We will move on to pathogenesis. In the pathogenesis, there is a chronic irritation of the bronchial mucosa by the irritants, mainly the tobacco smoke, also environmental dust, grain dust, silica, etc. So, it leads to excess of mucus producing goblet cells in the lining epithelium. There is hyperplasia and hypertrophy of the submucosal glands, inflammation and excess mucus production in also the small airways, ultimately leading on to chronic inflammation of the small and the large airways, leading on to fibrosis.